Hey, podcast family, welcome back to the Period Party. I'm your host, Nicole Jardim, and today I'm having Judy Ribner back on the show for a second time. Judy is a midwife doctor and the founder of Holistic Midwifery New York, the largest home birth practice in New York City. Judy's journey into midwifery was sparked by her deep appreciation for the innate power and intuition within the birthing process. Having completed her doctorate and graduating as the NYU valedictorian, Judy brings a wealth of knowledge and expertise to her practice. With a focus on preserving the physiologic process of birth, she cherishes helping individuals tap into their own strength and wisdom. In today's episode, we're delving into a topic that's often shrouded in mystery and concern, and that is tearing during childbirth. Judy breaks down the different degrees of tearing and sheds light on other potential injuries that can occur during labor and delivery. She also talks about the importance of proper labor positions and movement, exploring how strategic positioning can significantly reduce the risk of injury and tearing. We discuss practices like perineal massage and acupuncture, warm compresses and water immersion, breathing techniques, relaxation methods, and the significance of controlled pushing as part of preventing injury and creating an optimal birthing experience. Judy even talks about reducing risk of re-injury if you've torn during childbirth previously. Judy is a true advocate for birthing with wisdom, grace, and strength, and I hope this episode is helpful for you. If it is, please leave a rating or review on Apple Podcasts or Spotify and share on Instagram. You can tag me at Nicole M. Jardim and Judy at Holistic Midwifery NY. As always, thanks so much for listening, and I hope you enjoyed this episode. Hi, Judy. Welcome back to the show.
Hi, Nicole. I'm thrilled to be here.
Same, likewise. So, when we were recording that previous episode that we did together, you mentioned that you hadn't had anyone tear during delivery. And that, I feel like it sparked a whole other conversation about doing this episode on this topic alone, because this is a big concern for so many women. And so maybe we could start by just talking about what tearing is and what the different degrees of tearing look like. Because as I was saying, I looked that up online and I'm pretty traumatized. Just seeing all of that. I know it's not the most exciting experience, I'm sure, for women.
For sure. So to clarify, I definitely had tears at birth that I've attended, but I've also seen that the majority of women can be intact and not tear at all when they birth. So I have been to births where there have been tears, first or second degree, mostly. If there was a tear, it was a first degree. But if you want to talk about the definition of tearing, I think that's really important, because it's not like all tears are created equal.
Right.
When the baby comes out and the human body is stretching to the extent that it needs to, which is what it was designed for, in many situations, especially with the right precaution, and we'll go into detail how, in many situations, the body can and will be intact and not tear at all. But the body can tear either first degree, and that would mean skin only, or second degree, which is deeper, and that involves perineal muscles, which means muscles between the opening to the vagina and the anus. Third degree, which involves part of the anal sphincter, and fourth degree, which is more extensive and more involvement of the anal sphincter through like the rectum. So the third and fourth degree lacerations are ones that require more extensive repair and are often done in an operating room. Luckily, they're less common. I've personally never been to a birth where someone has had a third or fourth degree laceration. I mean, I've been to births where someone's had a scar from a third or fourth degree laceration in the past, but I've never attended a birth where a third or fourth degree resulted from the birth. And the first degree tears tend to heal quickest because they're most superficial. And many of them don't require any sutures, because if it's well approximated that the two sides meet up neatly and correctly in the body fold, and it's not bleeding, then there's research to support that allowing the body to heal on its own will have at least as good of an outcome as suturing a first degree. It actually might be less painful if there's no sutures in there. Glue, surgical glue, is another approach for a first degree. The second degree tears involve the perineal muscle, and those will take longer than a first degree to heal. They don't involve the anal sphincter though. And that for that too, there is research, and this is supported in ACOG, the American College of OBGYN, that there's clinical judgment. Does a second degree need to be repaired with sutures, or can it be left to heal on its own? Like, is it bleeding? Will it approximate well together? How deep is the second degree? And other variables, but there's clinical judgment in whether it's a stitch or not a stitch. It's not just like because someone has a tear, they should automatically have stitches. I want to debunk that as well.
Right. Anything else? I wasn't sure if you were going to continue going.
There is so much to do to prevent tearing during childbirth.
Okay.
Like, so much.
Yeah.
And if you look at research on hospital delivery, the majority of women who birth vaginally do have a laceration, which is why you're totally right, Nicole, really on women's minds when they have a baby, because it's almost associated as a normative part of childbirth that the body is going to be wounded and need repair. And that's not really true. In the majority of births that I've seen that were really physiologic and with real caution to prevent tearing, I've seen that the majority of women can and will birth intact, even women who've had lacerations in the past and have scar tissue. I will mention that when someone's going into a birth with scar tissue, like because they've had a second degree or third degree or fourth degree in the past, you want to be even more cautious. Then when we go into detail of what to do to prevent tearing, those matter even more for someone with significant scarring. A first-time mother also, you want to be more cautious with. Women who've had 3 intact births are more likely to be intact in the next birth, with needing to do less to protect them. That's what I will mention.
Okay. Yeah, that's so helpful. It makes me think of other injuries. Are there other injuries that can happen during labor and delivery, aside from tearing?
To the mother's body?
Yes.
Well, you could have hemorrhage, there's so many beyond tearing, but in the final moments of crowning, like as the baby's head is stretching the perineum and the vaginal opening, that's really when you want to be most cautious about a tear, because when women tear, it's usually in the very final minutes of the birth.
Oh.
People can also tear like a labial laceration or by the urethra or clitoris, like an upper structure tear, or vaginally. It doesn't have to only be at the perineum, like the muscular area between the openings of the vagina and the anus, but we're going to focus more on the perineal lacerations because those are disproportionately more common.
Yeah, for sure. I was just kind of curious, like what other things might happen. And I think that's helpful to know. So can we talk about proper, I don't want to say proper, but labor positions, maybe movement during labor and childbirth to reduce the risk of injury and tearing? I know that there are lots of I guess, opinions about the proper labor position for those who are in labor.
Sure. So you should know there's a lot of research on what to do to protect tearing. And I find that the research is conflicted. Like you'll read, oh, this birth position is protective, and then you'll read elsewhere it's not. Or you'll read water birth is protective, and then you'll read elsewhere that it's not. So I'm happy to share just from my own clinical experience, because I was going to say if we're going to use research, it's like really depends on the resource that you're reading. Yeah. Well, off the bat, vacuum delivery, forceps delivery, disproportionately put women at increased risk for tears and for extensive lacerations. Episiotomies also. Episiotomies will put a woman at increased risk for a third or fourth degree laceration. But in terms of no medical intervention, just a woman who's birthing, what can she do to protect herself? A lot. Firstly, what you just mentioned, physiologic birth position. What I've seen is that when women are in an upright position, not on their back with their legs pulled back or in stirrups, but on hands and knees, on all fours, or kneeling, I've seen that to be a protective position. And clinically, it makes sense just from a rational perspective. On one's back, the force of the head is more directed toward the perineum. The minute you flip over onto hands and knees, you have gravity shift the force of the head away from the perineum. I've also seen that doing something called flexion of the head has been protective, which essentially means that the provider keeps the head, the baby's head, well tucked with an anterior baby, so that the narrower diameter of the head comes out first without the baby in middle extending its head as it's being delivered. So maintaining like well control of the baby's head during the birth process can be helpful. And what's really I've seen really help is breathing the baby out during those final 2 or 3 contractions, like just at the point that the body is stretched to the max and the head can totally be born. If you have a good fetal heart rate and there's no need to expedite the delivery for a clinical reason, and you're able to guide that mother to, rather than give one big strong urge to push and birth the head forcefully and quickly, but gently, like breathe out that pressure. Give the body that little bit of extra time to gradually stretch around the head. I've seen that work magic for people. And I've also seen you soaking the body in a bathtub, like for an hour, hour and a half before the birth, can soften the tissue there and enable it to stretch more easily. Another trick we've used is oil. Just pouring like olive oil in the final moments as we're flexing the head, as we're breathing out the head, and as we're putting counter pressure to the perineum, like as it's being pushed against, we're holding it, that it doesn't just, get pushed open. So I'm aware that a lot of women are told to do perineal massage in advance of the birth process. And I just want to talk about that for a minute.
I'm so glad you want to talk about this because I was going to ask. Yeah, so sorry.
And it's a common question that we get, right? Because women rightfully want to birth with bodily integrity. They want their recovery to be easier. They want to protect their pelvic floor muscles because it directly impacts urinary continence, fecal continence, sexuality postpartum. Those pelvic muscles hold the internal organs in place, like the bladder, like the uterus, like the rectum. It matters to have strong pelvic floor muscles to prevent organ prolapse, like the displacement of internal organs. So there's so many important short-term and long-term reasons to have a gentle birth, a safe, gentle birth. And women, that's a common question prenatally, like, should I do perineal massage? And it could be that there's strong research, high quality research to support that perineal massage in advance of the birth process is helpful. It could be. I can just speak from my own experiences. We don't recommend routine perineal massage, and the majority of women are birthing intact. And I find that the perineal massage tends to become a burden for some women to do and painful, like for the weeks leading up. And I question, like, the tears that happen don't happen when the vagina is stretched to 2 inches or 6 centimeters. It's in that final bit as that 35-centimeter head is emerging. So when someone's doing perineal massage, are they going to actually stretch themselves to the 35 centimeters equivalent to a baby's head, right? The benefit that I can think of for perineal massage is to maybe help a woman get used to the idea of that stretching sensation, so that in the moment, as the birth is happening, to resist the urge to just push the head out, but rather sustain that sensation and breathe the baby out more gently. That's like the reason in my head I can think of maybe it would improve outcomes. Another piece here is, ACOG talks about using a warm compress, and water birth also is discussed in the literature. Like, does water protect the perineum? And I've seen both ways. I've seen situations where women sat in the birth pool for a while and you see how the tissue just stretches more easily. But I've also seen situations that women can be birthing in a birthing pool that limits visualization to the birth provider, which just limits how much the provider can guide and cautiously protect during those critical few moments. So with water, I don't think people should get a full sense of reassurance that, oh, I'm in the birthing pool, so that's protective. I think that you should do more than just rely on the water to be protective. That's what I would say.
Right. That's really helpful. What can you describe what perineal massage is? Because I don't know that everybody even really knows what that is.
Sure. Perineal massage, when it's done prenatally, means that the woman or her partner put two fingers inside the vagina, right by the and press downward on the perineum, on the muscle that's at like the 6 o'clock position between the vagina and anus, and gradually massage it and stretch it, and almost like if the baby were coming out, opening it up in preparation for the birth. Women who have perineal massage at the actual time of delivery, where the provider is stretching the perineum and putting pressure there, I would think, the way I was trained is to not do that, that it creates swelling in the tissue and that it could put the person at increased risk for laceration. And it doesn't feel intuitive to do that. I've also heard from other midwives that they've seen women tear from that massaging during the birth process.
Oh, ouch. Okay.
Yeah,
I mean,
I would assume. Yeah.
I
What
was
did you
just
want
going
to
to
say?
say, no, that's just so useful, I think, for people to hear, because I think that it's one of those things where to do it or not to do it. And there's a lot of mixed messaging and misinformation out there about it.
Yeah, but I don't also think that there's only one way. I
Yeah.
think that different providers develop different sets of skills and see what works for them. And there are providers that have very high rates of intact perineum, and there are providers with much lower rates. So I don't think it's that the women are defective. I think that it's really like the skills and what's being done. That doesn't mean that every laceration could have been prevented by a more skilled provider. There are lacerations that will just happen, but I really think it's provider dependent, the person's likelihood of being intact, just based on the variability amongst providers for that specific outcome. What we've seen a high degree of success with, especially in women who have a history of scarring or extensive scarring, and we've seen mothers birth intact after large episiotomy scars or multiple episiotomies or even a 3rd or 4th degree laceration. Like, I've really seen the human body's resilience and capability to heal, and the wisdom of how a scar can still stretch, even though it's potentially harder for it to stretch compared to actual tissue, but it can. And what we've done sometimes is physically just put one hand on either side of the scar, and as the final moment of the birth happened and the head was stretching against that perineum more and more and more, is to physically, with like a sterile gauze that's saturated in oil, hold the scar together on either side to create perineal slack and like extra space there, so that the scar isn't bearing the brunt of the pressure on its own. Right. And I've seen women breathe their babies out and do a gorgeous job at that. I've also seen sometimes birthing between contractions rather than with the contraction, really protective in a tough case. Like, the force of the contraction is going to help bring the head out more. But if the mother pushes that final push with the force of the contraction, there's more force. So if the mother gives a push between the contractions and that final bit to stretch her, it's less forceful. So if she pushes between the contraction and then with the contraction she breathes, then you can cautiously help that baby emerge. There's something called a compound presentation, where a hand can come with the baby's head. And when that happens, and I've seen women birth intact, even with a compound, but you want to be more cautious. When the hand is coming, you want to hold it tight to the head, so that the hand doesn't just separate from the head and extend itself and potentially tear its mother. So you just want to hold that hand and head well together so they get birthed as one unit. I will also mention that, and I've seen a midwife do this once and I've copied it, to ask a mother at the final stages of the birth to give a small cough, because it's almost like a little push, but without the force of the push, which is really another permutation of breathing the baby out, and rather than forcefully pushing the baby out. Directed pushing, which, I haven't seen it much when I was in the hospital system because I spent time with midwives, but directed pushing is still sometimes being done. Directed pushing is where the mother's being told by the provider to push. Sometimes it's directed pushing prolonged, like holding for 10 seconds for breath. A protective way to birth is the exact opposite. It's to push physiologically by one's own instinct, short pushes, breathing in between, and at the end, really trying to bring the baby out. If clinically it would be safe to do so, which in most situations it is. What was that, Nicole?
No, I was just going to say to you that it just makes me think of all of the TV shows and the movies out there, because I feel like every one of them almost portrays women during labor just laying on their backs and someone's kind of shouting at them to push. And it's a little cringy, because now you're telling me that that's rarely that directed labor is rarely done anymore.
It's rarely needed, and it's physiologically right. It's rarely needed. I was going to say there are circumstances where it is, but in the majority of situations, it's not needed nor beneficial. Now, the problem is if someone's numbed and they don't have any urge to push and don't have any instinct, like meaning to direct them, that's where directed pushing can be more useful. But in a physiologic situation where the woman is unmedicated and feeling the sensations of labor, in the majority of such situations, pushing physiologically by the woman's own urges is going to be her best way. That's what I would say.
Yeah.
And another thing is, like, the stirrup position. We have to reevaluate if the current literature is saying that the majority of hospital deliveries, vaginal deliveries, result in laceration. We need to question what is a common factor amongst those deliveries. And one is that the common hospital delivery position puts undue pressure on the perineum by the baby's head, and it's not a physiologic birth position. So that's not a setup. It doesn't mean a person couldn't be intact. Some women will be intact in that position, but it's not a setup for success. That's what I would say. I think being careful with the shoulders is another important piece here. Like, that's also a wide diameter of the baby's body. Once the head is born, to cautiously guide the shoulder out, and whether that means to have the assistant to continue to hold the perineal scar or counter pressure the perineum or pour oil or warm compress and be gentle as the shoulder is emerging. I think being attentive to that matters. I think that some of the tears that happen aren't necessarily the head, but sometimes it's the shoulder.
All right, which makes sense. I mean, it's definitely wider. So that does make sense. Yeah. So I wanted to ask you about a friend of mine. She had mentioned to me that she just massaged the whole perineum area and her vaginal tissue with oil beforehand. And she felt like that was super helpful for her. So I know you've said that there are different strokes for different folks, basically. So what are your thoughts on doing something like that? Do you feel like it's helpful for some, maybe not for others?
Yeah, I think it could be helpful. I do think so, but I think there's also so much that can be done at the birth itself to protect women that I don't know that women have to burden that for the 4 weeks leading up to the birth.
Okay.
But I do think it could be helpful. Yeah.
Okay. And then what about acupuncture? Because that's another one I hear too, in addition to the perineal massage, of something that can be helpful for tearing or to at least support the tissue elasticity. I don't know how true that is.
I love acupuncture and I refer for it routinely, but I don't know if that's going to directly impact the final stages of the birth. I've seen the proactivity of the birth provider and working with the mother. I've seen that work magic, like really successfully for the majority of women. So I look at my responsibility, let's say when I go to a birth, is to ensure the safety of the baby and also to ensure the safety of the mother and also to try to protect the mother's body so that she has a gentle birth experience. Like, I see it as part of the clinical judgment and clinical skills that the birth provider should be bringing to the birth. That's how I see protecting the perineum.
Yeah. No, it's beautiful. And, I was thinking actually, when you mentioned forceps, I was a forceps baby. My head was really big. And, and it was just how things were done back then. So I think about how traumatic that is. Is that you did mention though, that those kinds of interventions can definitely contribute to more physical damage, right?
Yeah. Yeah. Okay. A vacuum delivery, a forceps delivery, and a episiotomy, one of their risks are extensive lacerations.
Right. Okay.
Now, when it's a life-saving intervention, then you know what I mean? I'm glad those interventions exist, but it is one of the risks of those interventions.
Right. Well, we're going to come back to episiotomy, but I wanted to just talk about the water immersion that you just mentioned a little while ago during labor. So, do so I know what you said about water immersion, but what about it when you're actually giving birth in the water? Does that reduce your risk of tearing or any other potential lacerations? Like what is your opinion on it?
There's research that supports that water birth is protective to the perineum. What I've seen, just practically speaking, is that sometimes the water is just protective because the mother's been in there for a while. So it softens the tissue, it makes it easier to stretch. But I've also seen the opposite. I've seen where, yes, it helps the tissue stretch, but if the mother's in a position in the birthing pool that the midwife physically can't put her head in the water and look underneath, right? Like, and on dry land, you can get into any position as a provider. You could be flat on the ground protecting the perineum in the birth pool. You don't have that level of visualization. You don't have the ability to get into any position for her. So if you're birthing with a provider who has the skills to protect the perineum, if you're going to limit their ability to see or access the perineum, then that might put the woman at increased risk for just less protection. But the water itself, sitting in there for quite some time, it will add a layer of protection. Just I wouldn't recommend just relying on that. That's what I would say.
Okay. Yeah, no, that makes a lot of sense. And again, I feel like it's so personal and it just depends on who you are and what your preferences are, I imagine.
Yeah.
So, can we talk a little bit about episiotomies? Because I feel like these are very controversial. And obviously, if that's happening, I assume it's to prevent tearing. Can you just discuss like what the situation is when a doctor or healthcare provider might do something like that?
Yeah, so an episiotomy is a surgical incision into a woman's perineum, and there are different ways to cut that incision, like at different angles. And after 2006 in the United States, there's been a very steady decline in episiotomies
Oh,
because mainstream medical guidelines endorsing routine episiotomy use and encourage restrictive use, that it should be based on clinical judgment, but not that just because someone's having a baby that they should have a surgical incision. So if you think about that rationale, and episiotomies have been associated with an increased likelihood of third and fourth degree lacerations, because once you're cutting and breaking the tissue integrity, think about the likelihood of it to just extend, right? Like imagine you tear a sheet of paper, now there's weakness there, and the whole rest of the tear can just keep going.
yeah.
Also, if you think about it, like what? The rationale to cut someone to prevent the tear, I mean, you're doing a surgical incision, you're cutting through layers of muscle. The whole point is to protect them, that they shouldn't tear their muscles, they shouldn't even tear their skin. So I personally haven't ever cut an episiotomy, but are there situations that clinically it could be warranted, like to expedite a delivery where those moments would make a difference? Of course, but those situations are uncommon, and routine episiotomy use is an outdated medical practice by mainstream medical standards. And I do recommend that if a woman is choosing a provider, to ask, what is your episiotomy rate? Like if she hears a number like 60%, you know, if she doesn't want to end up with an episiotomy, she should rethink if she's setting herself up for success.
Yeah. Well, that makes sense. And I'm thinking about tissue integrity as you've been talking about all of this. And I'm curious, um, I mean, this is sort of my domain, I suppose, but like from a nutrition perspective, I feel like there's so much we can do to support the health of our tissues and the skin, in that area. Is there anything that you recommend, or do you see situations where maybe a woman is older and she's more likely to tear, or the tissue is more likely to tear? Can you talk about that? Do you have any experience with all of that?
You're bringing up such a good point, especially if someone has a scar, right? Wound healing capability varies from individual to individual and is influenced by overall health status, including nutritional status, like protein, vitamin C, right? Like, but I've seen, even working with a diverse population, hospital in the past, when I was in the hospital system, and now in a home birth setting, I've really seen the majority of women can and will be intact with the rightful precaution. So
Right.
I look less at those factors and look more at what can I do during the birth process to enable that head to emerge gently and slowly at the end, and physically hold that scar together and birth in a position that's optimal, or birth between contractions. I've seen that work so well, I put less emphasis on who the person is and what their risk factors are.
Right. No, that's really good to know, because I wasn't entirely sure if there were sort of like pre-existing issues that one should be thinking about, or, concerns with nutrition and things like that. I mean, imagine, like, yeah, there's always those kinds of things, but the fact that you're talking about in the moment being the most critical piece, for at least for you and your experience, is so helpful, I think, for people to hear.
Yeah. But you are bringing up a good point. Like, the inter-individual susceptibility to tearing is going to be influenced by genetics, but also health status, wound healing, all that. I totally agree that does probably play a role.
Right. And so you've definitely talked about scarring, and I would love to explore that a little bit more. So, aside from what's happening in the birth itself, what are there other advice, or is there other advice or recommendations for individuals who have had previous tearing during childbirth and they're concerned about this risk of re-injury during subsequent births?
And by the way, sometimes it's those women who are most motivated to be intact in the future because they've suffered sometimes in the past a long recovery or pain with sex, months postpartum, which, by the way, is disproportionately likely with an episiotomy, and that's in mainstream medical literature, that the resumption of sex postpartum is going to be more likely to be delayed and more likely to be painful in someone who's had an episiotomy compared to a natural tear, just so you know that.
Yes.
But, and those women are so motivated sometimes. Like, I'm thinking back to some of our births where mothers had episiotomies or extensive laceration, and just like how hard we worked and how appreciative they were and how amazingly they worked, like, in those final moments. It wasn't just like, okay, push, 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 push to get this baby out as the head is coming. It was like, is it safe for me to give a push? Should I breathe? Like, the mothers work really hard to protect themselves, and it's amazing. And for those women, I would say, for sure, eating well, good nutrition to promote good wound healing capability. That's one piece. And then really also trying to align oneself with a provider who has a high degree of success for that specific outcome measure. The American College of Nurse Midwives published this recently, that when it comes to third and fourth degree prevention of third and fourth degree lacerations, they found that having 2 midwives in the room as opposed to 1 midwife during the birth process has been protective and has reduced the rate of third and fourth degree lacerations. And they also reported the variation in rates amongst hospitals is quite wide, which is what indicates that it's largely dependent by provider practice.
Mm.
And I think that's really important, because it means making an informed decision with who is going to be at your birth. Who are you trusting to protect your body with, and also ensure the safety of your baby? But who are you protecting your body with really matters.
It really does. I mean, that to me is so empowering, because you have so much control over that, like who you're going to
Right,
be working with. Yeah, I completely
right.
agree with that. It's a really great point, and
Home
I
birth is
appreciate you bringing it up.
associated with a reduction in episiotomy rates, by the way, in the research. Physiologic birth, one of its benefits is protective to the mother's body, right? Like, she's birthing in a position that is most comfortable to her, is most intuitive, it's instinct led, it's not directed pushing, it's the way nature designed it to be. So it's a common sense research finding that physiologic birth is protective to the perineum, right?
Mm-hmm. No, it is. And so is there anything else that you feel that anyone who is either pregnant or thinking of getting pregnant and is really worried about this, because this, like I said before, right, this is something that I've heard so many times. Even I thought, like, if I got pregnant, that would be one of my bigger concerns, just because I've heard so many stories about it over the years. Like, is there something that you would tell someone who is concerned about this? Like, where do they start? Like, what should they do? Does it start with the practitioner that they choose to be birthing with?
Yeah, straightforward. Yeah.
Mm-hmm. And then bringing those concerns to that practitioner, I imagine.
Yeah. And discussing in advance, right? Like interviewing well and choosing someone who's aligned with their value system and with the goals of the kind of birth they want to have, and a provider who has those kind of outcomes. And then discussing with that provider in advance, like, how will we work together? What's our strategy? And if the provider says, I find X, Y, and Z to be protective to my client, to participate in that, like whether it's a recommendation in advance of the birth, whether it's a recommendation during the birth process about positioning or about guiding the birth at the end, like if it matters, it should be talked about prenatally.
Right, for sure.
And really before choosing the provider. Yeah. Like in the initial consultation.
Yeah, of course. And okay, so there's something else that I want to talk about before we wrap things up. But when we were talking about episiotomy and tearing and all of these things and getting stitched back up, it's funny. I was actually at a friend's birth many, many years ago. It was my first and last birth that I was at. It was the most incredible experience, but it was done naturally without an epidural or anything like that. And the only time she screamed was when they had to stitch her back up. I guess I think it was when they gave her the painkiller. Yeah, the lidocaine, exactly. Right. Yeah. And so that was the most painful part, I imagine. But I was like, you just pushed a baby out. How is that worse? But I've heard these stories over the years about the stitching not being done right, or the husband stitch, which is so mind-boggling to me. Can you talk about this? I can see your face, so I know that you're annoyed by this whole thing. Let's talk about it.
Yeah, you're bringing up an important part. I've also heard feedback like that I've heard women say that the recovery from the stitches was harder than the labor process, right? Well, of course, everyone's recovery is different. Everyone's labor process is different, but I've definitely heard women report like a high level of suffering postpartum, or needing reconstructive surgery, or everything that you're describing is very real. And that's why this discussion is so important, because if we're saying that there's research drawn from care with midwives that the majority of women are intact, and I've seen that clinically to be true, then we know that the majority of women shouldn't need to suffer this. And even if someone does tear, as we discussed earlier, there's different extents of lacerations. It's not like all tears are created equal, and there's different approaches. Should it be stitched? Should it not be stitched? Depending on the severity and other clinical components. So this is so important to talk about, and you should know, when I was 18, someone told me, yeah, everyone who has a baby gets stitches. And I was so surprised by that. Like, isn't birth a natural process? How can it routinely depend on an industrialized product in order for it to work, right? Think of suture material. It's not grown in nature. And I went and asked a number of women, that I could get away with asking such a question to, and said, like, did you have stitches after you had your baby? And you're going to hear like, oh, with the first, yeah, everyone tears with the first. And that never sat well with me. I refuse to accept that our species is that defective, that every woman should need stitches. I understand that some people might, and I'm not, God forbid, implying that they're defective. I just need to say that to think that the process was missing that detail for every single person routinely, it didn't make sense, and it never felt right to me. So I actually did a lot of research into it years ago, even before I became a midwife. And that's where I read different midwives sharing their perspectives on an internet read one. And it was fascinating to hear the level of commitment and responsibility and motivation that some of these midwives shared toward protecting women during the birth process. Midwifery model of care is associated with a reduction in laceration compared to the medical model of care. It's one of the benefits of midwifery model, and I discussed it's one of the benefits of home birth specifically. It's one of the benefits of like a reduction in episiotomy rates with regard to home birth. It's one of the benefits of physiologic birth. But women have the right to not suffer, and women have the right to do everything they can to prevent that if they can. And if someone does tear or they tear extensively, I don't think that they should lose confidence in their body or view themselves differently. I think that if they're going to have another baby, they can reevaluate what they can do differently. And sometimes it is unpreventable, and I'm holding space for that as well. I really, truly am. But my message is that the majority of women can be intact, and there's a lot to do to try to meet that goal.
Thank you. This was so good. I feel like this was a shorter conversation than the last one. And anyone who has missed the last conversation, they should definitely tune back into that one because it was really great. But Judy, thank you so much. As always, you just share incredible information that I think is completely game-changing for so many people who are listening. And I just appreciate your time so much. So thank you.
Sure. It was an honor and a privilege, Nicole. Keep up all your advocacy of women's health. I really admire you.
I appreciate that. I admire you. Can you remind everyone where they can find you, your practice, and all of your work?
Sure. We're at Holistic Midwifery NY on Instagram, and we're based in New York City. So we also have a website, holisticmidwiferyny.net. So,
great. Thank you. Thank you so much.
So keep up your amazing work.
Thank you, Judy. Okay, bye. That's a wrap. Be sure to click that subscribe button to join me for more Girl Talk Gone Menstrual in upcoming episodes. But in the meantime, check out my latest Period Party episode. And if you're looking for a deeper dive into your hormones, go ahead and take my period quiz at nicolejardim.com/quiz.